Hi, I'm Dr. Felice Gersh, your integrative OBGYN physician. I travel all over the US and the world giving lectures on many different topics involving women's health. And lately, as menopause is so incredibly trendy and appropriately so, I have been talking a lot about issues involving hormones and menopause. And I talk about how I recommend hormones be given. Right now, many more women and healthcare providers are really aware that menopause is not just about the end of fertility, it's a huge metabolic shift in the female body affecting virtually every single organ system. So now we have a lot of acknowledgement, recognition that menopause is a big deal. This was recognized way back decades ago, but then it was like the wisdom of the ages was lost after the Women's Health Initiative, and it's making a comeback. So recognizing the significance of menopause is step one. But what about the treatment? So, as many of you know, I recommend cycling the progesterone, meaning I give it for only a portion of the cycle. A cycle in a normal reproductive aged healthy woman, the classic is 28 days. It is cyclic hormone treatment. You give progesterone for 14 days, and you give the estradiol, that's the form of estrogen that you should always be giving or receiving. You give that every day, no days off from estradiol. But progesterone, 14 days on, the rest of the month, no progesterone. So I get a lot of questions because a lot of doctors are no longer prescribing it that way. The original prescriptions for hormone therapy, going back quite a ways when progestins were added, that was predominantly in the 1970s, was cyclic. And when they did two of the most prominent studies, the KEEPS study and the ELITE study, which I'm not going to go into what those studies showed, but those studies have been considered very prominent, and they used cyclic progesterone. So I didn't invent it, I'm just using it because it is most aligned with how women's bodies were evolved to work. So here are some of the questions. I'm going to give you the 5 top questions that I get over and over after I give my talks about how to prescribe hormone therapy. And for many in the audience, doctors and prescribers of other types, and patients as well, because most of my lectures are to medical professionals, but I do occasionally talk to the general public, usually women, but few men show up, which is wonderful. So what are the 5 top questions I get over and over? Number 1, if I am cycling the hormones, and by the way, if you cycle correctly, meaning that you give an adequate dose, a physiologic dose of estradiol and progesterone. And what does that mean, physiologic dose? It means it's approximately or in the ballpark of levels that healthy reproductive aged women would have in their bodies, like at the time of life when you are the healthiest, okay? That's what we want to have in our bodies so we can be optimally healthy, whatever our age, going all the way out. But the question that I get is, if I'm cycling the hormones and getting a bleed every month, because that is the goal. If you give physiologic doses of estradiol, you will grow the uterine lining because you will make growth factors, which is great if you want to have growth factors for neuroplasticity, neurogenesis, repair, maintenance in your brain, or you want to have growth and maintenance in your bones, maintenance, repair in your arteries, etc., etc. You need to have growth factors. When you take hormones in a physiologic dosed way and a cyclic way with the cyclic progesterone, you will grow the uterine lining which is good. And then you are on the progesterone, which will shed the uterine lining. Because you know this little motto that I created, if you grow it, you must shed it. You can't just keep growing, growing, growing. And we wouldn't want that. We want progesterone. We love progesterone. But here's the question, okay, in case you wondered, where is that question? It's if I'm cycling the hormones and I'm getting a monthly bleed, does that make me fertile? Can I conceive? The answer is no. Now, if you are reproductive aged and you have a condition like polycystic ovary syndrome, then I might actually, by giving you these hormones, in fact, it's not just possible, it's highly probable, I will make you, as a reproductive age woman, healthier and actually more fertile. But if you're in menopause, your ovaries have gotten, used up as far as their egg supply. The egg supply is gone. You are no longer making any estradiol or progesterone. Those days are gone. And I give you these physiologic cyclic regimens of hormones, and you bleed like a mini period, or like a period. I am not making you fertile. I am not resurrecting your ovaries. But what I am doing is optimizing the health of every organ system in your body. But I am not rejuvenating your ovaries in menopause when all the egg supply is gone and you're not making estradiol or progesterone. So don't worry, you can't conceive just because you're having cycles, okay? I am not making you fertile in menopause. The next question that I get so frequently is, if I'm cycling the hormones and I'm bleeding, isn't that increasing my risk of uterine cancer? The answer is a flat no. That if you are giving progesterone to achieve levels that are comparable to what a woman in her reproductive years would have as far as her levels of progesterone, and you're maintaining the estradiol levels in the physiologic range, sort of an average-ish level that a woman would have during the course of a normal menstrual cycle when she's, say, age 23, I am lowering or absolutely not increasing the risk of endometrial adenocarcinoma. That's cancer of the uterine lining. Because when you grow the uterine lining and then you shed the uterine lining, you're purging the uterine cavity of potentially cancerous cells, and you're not having unopposed estrogen delivered in an inflammatory environment. Now, that is not to say that every woman who goes on appropriately dosed cyclic hormones cannot get uterine cancer. But what I want you to know is we are certainly not increasing the risk one bit, not one tiny bit. And although I can't prove it, looking at physiology and looking at the science of what's going on in the uterine cavity with growing, that's proliferating, and then shedding with the progesterone, the most medically probable scenario is that I am lowering the risk. If you think about who gets adenocarcinoma of the endometrium, is it healthy young women who are having cyclic normal periods? The answer is no. They almost never get uterine cancer. Uterine cancer, now when I say uterine cancer, I'm talking about adenocarcinoma of the uterus, which is cancer of the uterine lining, the glandular part of the inside of the lining. That almost always occurs in postmenopausal women. And the other group that has a higher risk of adenocarcinoma of the uterine lining, endometrial adenocarcinoma, are women who have irregular cycles and a lot of inflammation in their bodies. And what group is that? women with polycystic ovary syndrome. And in fact, I personally know of women with PCOS who developed adenocarcinoma of the endometrium in their 20s, as shocking as that sounds. But that is not the healthy, cyclic, fertile woman. These are women who have a lot of visceral adiposity, that's, the belly fat, the fat in their livers. They're highly inflamed and they don't cycle. They don't have regular cycles. They're not shedding the uterine lining in an appropriate way every month. So in terms of the reproductive years, it's that group of women that tends to have a higher risk of adenocarcinoma of the endometrium. And the other group, which is the most prevalent group, are the women who are postmenopausal, who are not on a physiologic cyclic regimen of progesterone and estradiol. So I don't want you to be afraid. The bleeding that you get when you have cyclic hormones is shedding or purging the uterine lining. It's not abnormal bleeding that occurs when you have abnormal hormone imbalance, I should say, and the uterine lining becomes irregularly growing. And so you have what could be disordered proliferative endometrium. That means that the uterine lining is all different heights, and when it gets too tall, it's unstable, it just falls out. Or it can be because you have hyperplasia, which is a generalized overgrowth, and it can go down the path of cystic hyperplasia, which is just the glands get really large, kind of like the holes you see in Swiss cheese. Or you get atypical hyperplasia, where you're getting abnormal cells in the glands. So that can happen mostly in women who are not cycling, who are not on appropriate doses of progesterone cycling with appropriate doses of estradiol, or they're just not on any hormones and they're systemically inflamed, which will be inflammation of the whole body, including inflammation of the uterus. And when you have inflammation in the uterus, you have DNA instability, which can lead to cancer developing in the uterine lining. And the uterine lining, when you're under a very inflamed situation, will actually trigger the upregulation of the enzyme aromatase, which will convert androgens, like male-type hormones, which come predominantly from the adrenal gland, into predominantly the estrogen called estrone, which triggers uncontrolled proliferation or growth. And when you have an environment with uncontrolled growth or proliferation and inflammation, where you get DNA instability and breakage, and then you have all the growth factors from estrone out of control, because it's not estradiol, it's estrone, which doesn't have the balance effect on anything, and you just get uncontrolled growth and uncontrolled inflammation. That's the ticket to cancer, whether it's in the breast or in the uterine cavity. That has nothing to do with getting cyclic hormones. I just want to make that clear. So if you are having appropriate bleeding, withdrawal bleeding from appropriately physiologically dosed estradiol and cyclic progesterone, that is a good sign that you don't have cancer or precancer developing in your uterine cavity. Of course, if there's irregular bleeding, that should always be investigated. And if you feel more comfortable, you can always have ultrasounds of the uterine lining when, after the shedding, that's when the uterine lining would be the thinnest, or you can always undergo a 2-minute endometrial biopsy in the office. So quick, so easy to do if you feel anxious about it. Nothing wrong with that. Now, the third question that I get asked all the time is, But isn't it abnormal to bleed after menopause? Menopause means you stop bleeding. Well, yes, that is true. It is not normal to bleed after menopause. Certainly, it's not normal to bleed after menopause if you're not on any hormones, because if you bleed, that's immediately suspect that it's a precancer or cancer of the endometrium, of the uterine lining. But nothing that we do in medicine is natural. What we try to do as doctors is find the safest, most efficacious way to restore harmony and balance and health in the body. Now, aging is a universal phenomenon, and aging is not a health inducer. No matter how we put it, the older we get, the more we have to fight like crazy to stay optimally healthy, because nature isn't really that kind to aging creatures, okay? So aging people are more likely to get things like osteoarthritis, osteoporosis, dementia, all the cardiovascular issues like hypertension, heart attacks, strokes, and then more likely to get cancers, GI problems, malabsorption. So all of those things are natural. You want natural? Don't come to me, okay? Because you don't need me to have natural. What I want to do is take the situation for each individual and do everything I can in a way that's most aligned with reestablishing optimal health in the most natural way, consistent with physiology. So I'm going to give hormones. That's not natural. Natural is not to have hormones after menopause. But the hormones I give are going to be human identical, and I'm going to give them in a way that somewhat-ish mimics the hormones in terms of rhythms and levels of a woman at her peak health, like in her early 20s, when she is healthiest, most fertile. They've shown that with men. If you give a man testosterone, do you want to give him a level of testosterone that's similar to a man who's 50, say for a man who's 60? Or do you want to take that man who's 60 and get him to a testosterone level that's comparable to the level of a man in his early 20s? You do want to get it down, I should say up. You want to get the level of testosterone to be in the range of the healthiest young male, like in his early 20s. And for women, we should do the same thing. We should give hormones that are going to be similar to the levels and rhythms of hormones of women in their early 20s. And women in their early 20s, if they have optimal hormones, they're having perfect, nice, regular cycles. And they get perfect, nice, regular periods. If you want every cell in your body to optimally function, you have to give them optimal hormones. It's that simple. You can't be optimally functioning with suboptimal hormones. I can't recreate age 21, but I can come a whole lot closer than what is being typically prescribed. So yes, it is certainly abnormal to bleed in the menopause. But what's normal is all those bad things I described. Let me say them again. You want them? I don't think so. Osteoporotic fractures, joint replacements, or pain due to osteoarthritis, hypertension, which is the #1 risk factor for heart attacks and strokes. Women without the best hormone replacement will have a risk of, the incidence of hypertension is so high. By age 65, 75% of women will have hypertension. They'll reach the levels for being diagnosed with hypertension. You can likely, medical probability, do we have a lot of clinical data? We have science. We know the mechanisms. We absolutely know the mechanisms, and I'll talk about those more another time. If you want to have optimal health, you need optimal hormones. And yes, that means cyclic hormones where you get physiologic dosing and physiologic rhythms, and you will bleed. And you know what I want you to do? Celebrate it. It's how you frame it in your mind. If you see that blood and you say, yay, it means my body is getting appropriate levels and rhythms. My body is working more like a younger woman than an older woman. I don't want all those medical problems. I can't stop aging. I want to slow it. Okay? So I want to delay. So the stuff that most women get at 65, I want you to be over 95. Okay? That's my goal. So that bad stuff doesn't happen till you're approaching 100 and you live with tremendous energy and vitality. And that means, yes, you will bleed. And yes, it is not normal. Natural kind of sucks. Okay? So I'm not for doing things that are not aligned with optimizing health to get the body to work the way it should, giving the most natural approach. But I recognize, yes, it's not natural to bleed after menopause, but I don't want what is natural because, like I said, it kind of sucks. Now, the next question is, if I give higher amounts of estradiol, will that increase my risk of breast cancer? Oh my gosh, there's so much fear of breast cancer, and it's not inappropriate. Over 40,000 American women die every year from breast cancer. It is unfortunately very common. So I'm not saying breast cancer isn't a big deal. Of course it's a big deal. And we all are at risk. Men, very little. They have little breasts, to say the least, but there's a rare incidence of breast cancer in men. And it's a very common cancer in women who universally have breasts. So of course it's a concern. But by giving physiologic levels commensurate-ish with what a woman in her early 20s would have who's having normal menstrual cycles, is not increasing your risk of breast cancer. In fact, there's published data saying that estrogen lowers the incidence of breast cancer by about 33%. It's more limited in research, but we know the scientific mechanisms, how progesterone, human bioidentical progesterone, not progestins like they used in the Women's Health Initiative, medroxyprogesterone acetate, 2 thumbs down. If I had more thumbs, I would have more thumbs down for that particular chemical. That is not a human hormone. Let's not go there anymore. But with human identical progesterone, progesterone down regulates the estrogen receptor alpha. So I've talked about it. I'll talk about it more, that there are 3 estrogen receptors. Alpha is the one that creates growth factors. And of course, you need growth factors. I talk about that all the time. Brain-derived neurotrophic factor, nerve growth factor, vascular endothelial growth factor, transforming growth factors. We can't grow new tissue. We can't maintain tissue. We can't repair. We can't do any of that without growth factors. So of course we want growth factors. That's the ticket to healthy longevity. But here's the problem. If you have too much of the growth factor that's not balanced by estradiol, that's where you can get into trouble. So let's talk about what can and can't happen with human bioidentical hormones and breast cancer. Well, let's talk about, and I'll talk back more about progesterone in a second. So estradiol. Estradiol, I just mentioned, can lower the risk of breast cancer. Now, what's the mechanism? We know the mechanism. That's not mysterious. So, underlying breast cancer development is uncontrolled inflammation in the breast. Now, older women generally speaking, have systemic, that means total body inflammation for a whole host of reasons, leaky gut, immune cell dysregulation because you don't have the estradiol. So what does estradiol do that lowers inflammation? Well, estradiol balances, it modulates the immune system so that you don't go into a pro-inflammatory state as the sort of standard state. Without adequate estradiol, the default state, because the body makes estrone when you have inflammation, and inflammation is often very based in adipose or fat tissue, the enzyme aromatase, that is the enzyme that converts androgens to estrogens. That enzyme is upregulated. It's like on high mode, okay? And then what happens is you convert the dominant androgens from the adrenal gland, DHEAS, into estrone. Now, I've already mentioned that estrone turns on the alpha receptor, which creates, if it's unbalanced by estradiol and the beta receptor and the G protein coupled receptor, when it's unbalanced and you have only estrone, because when you make estrone and you have a lot of inflammation, it downregulates the enzyme that can convert estrone into estradiol. So you're stuck in estrone with uncontrolled inflammation and uncontrolled proliferation or growth factors. That's what I just explained can increase the risk of uterine cancer in postmenopausal women and PCOS women. Well, what about the breast? Here's a good, easy thing to know. It's the same mechanism. So all these things are replicated all over the body. So you learn it once and then you can understand it when I talk about a different organ. So in the breasts, in postmenopausal women, the breasts become very inflamed because the woman is overall inflamed. I mentioned a few reasons. Another one is leaky gut that causes endotoxins in the gut to come into the body itself and activate immune cells to make a lot of inflammatory cytokines, which further induce more inflammation. So when you have a lot of inflammation, you end up with upregulating the enzyme aromatase and you make more estrone. If you have inflamed breasts and you have a lot of estrone coming in from peripheral production, like in fat tissue around your liver, your belly, and also the breasts have a ton of fat, you make it in the breast locally, that estrone. So that's the perfect ticket to breast cancer. Inflammation, creating DNA instability and breakage, and estrone creating uncontrolled growth factors or proliferation, which can grow an incipient breast cancer. But what does that have to do with giving physiologic levels of estradiol? It doesn't, because when you give physiologic or good, we'll call it good levels of estradiol, commensurate with what a reproductive age woman would have, you downregulate the genes that control aromatase activity. So you will make less estrone. You downregulate inflammation. So you'll have less breast inflammation. 2 thumbs up for estradiol. Less systemic inflammation, less inflammation in the breasts. Lowered activity of aromatase, lower production of estrone. Less inflammation, less estrone, less breast cancer. You got it? Now, what else? Well, it turns out that women who are on hormone therapy who develop breast cancer, because look, women who are perfectly normal in every way, or so it seems, and they're 35 can get breast cancer, even younger. So we can't control everything because we live in a world of chemical soup. But we'll deal with that chemical soup issue another day. But there are reasons why women, even if they have perfect cycles, even if they're on perfect hormone therapy with cyclic physiologic dosed hormones, can still get breast cancer. So what if they do? they have a better prognosis if they're on hormone therapy. Now, why would that be? Well, progesterone down regulates the alpha receptor so that you will have less activation of proliferation when you have progesterone around, bioidentical progesterone, human type. What else? Estradiol controls the gene that deals with cohesiveness of cells. So if you have a breast cancer at any size, it doesn't have to do with size, it has to do with, we'll say, the quality of cohesiveness. If all the cells are closely hooked together, like they're super glued together, no matter how big that breast cancer gets in the breast, we won't have cells flying off and metastasizing, spreading to other organs. It's the spread to other organs that kills. No one dies of breast cancer in the breast. They die of metastatic disease, where it goes to the brain, to the lungs, to the liver, to the bone, anywhere, okay? That's what kills women from breast cancer. So when you have estradiol at physiologic levels, you're more likely to have cohesiveness of those cells, so they're less likely to break off. When you have very low levels of estradiol, then you're more likely to have, it's like held together by spit, and the cells can break off and travel in the lymphatics or in the blood vessels in the arteries to distant sites. So that is another incredible thing that estradiol does. Estradiol also controls what's called the cell cycle, which is through the mitochondria. That determines when cells that are yucky, old, senescent, sometimes called zombie cells, when they commit cell suicide, called apoptosis. Estradiol controls that. Potentially precancer cells, when you have adequate estradiol, they kill themselves. That's the mechanism why we don't get so much cancer when we're young, and why endocrine disruptors for estrogen increase cancers of all kinds, okay? So we definitely want to have adequate levels of estradiol so that it controls the cell cycle. Now, what also happens is we'll have healthier cells, less likely to get those senescent inflammatory zombie cells when we have adequate levels of estradiol, because estradiol is what triggers autophagy and mitophagy. Autophagy is when cells renew themselves. It's like spring cleaning in the cell itself. And the same for mitophagy, mitochondria cleaning house inside, so that you get like rejuvenated cells from the inside. Estradiol is essential for that. Estradiol is essential for the production of most peptides, for the function of the enzymes called sirtuins, and work synergistically with NAD, which is critical for cell function and for DNA stability. So there's a host of mechanisms that physiologic estradiol does to lower the risk of cancers, including breast cancer. And I mentioned progesterone downregulates the alpha receptor so that you will have less uncontrolled proliferation or growth that can stimulate an incipient developing cancer that has estrogen receptors for alpha, and that tends to be uterine and breast. Okay? So I hope you will believe me when I answer that question I get all the time. Will taking higher doses, physiologic doses of estradiol, increase my risk of breast cancer? Do I need to take the lowest dose? The answer is you take the best optimal dose, which is physiologic. Low doses of estradiol will not create these effects anywhere near the same. In fact, low doses of estradiol, that's not going to be so anti-inflammatory. It can even be more pro-inflammatory because you don't have enough, okay? So we do not want to have suboptimal dosing of anything, and for sure for estradiol and progesterone. Now, the next question is, how long do I stay on this regimen? Am I going to cycle and have like pretend periods? It's real blood, but like pretend periods forever? The answer is, I recommend it, but it's your choice. You can always say, you know what? I'll take my chances. I just don't want to do this anymore. That's always your choice. You could say that about anything. I don't want to eat vegetables anymore. I don't want to exercise anymore. I don't want to go to bed at a reasonable time anymore. Do I recommend any of those things? Of course not. I'm a doctor. I want you to do everything optimally. But it's your life and it's your choice. What would I recommend? I recommend that you have cyclic hormones for the duration of your life. As long as you want to be optimally healthy, you'll have optimally dosed and rhythmic cycling of these hormones, these vital life hormones. But if you say, I've just had it, I don't fight with anybody. It's your life, your choice. But it's just like exercise. If you say, I'm 75, I'm 85, I don't want to exercise anymore. I don't want to go to the gym. I don't want to lift weights. I don't want to do any aerobic exercise. I'm tired of it. Well, your choice. Would I recommend that? Of course not, because we know that you can start exercise at any stage of life, 95, and still get benefit. You can still get benefits of cyclic hormones, in my opinion, at any stage of life. Remember this. Very few cells in your body are the same ones there from when you were born. That's why we have stem cells. Cells live and they die and they get replaced. When a new cell is born from your stem cells, it has no idea how old you are. So when you make a new bone cell, they usually live about 7 years. It dies. You make a new one. That new bone cell, it doesn't know how old you are. It's genetically programmed to do the same at age 70 as at age 25. But it can't do everything the same at age 70 as at age 25 if it doesn't have all it needs. The micronutrients, the macronutrients, the hormones, and not have a lot of toxicants, chemicals that are destroying how cells can live and function. We want to have everything as close to optimal as we can, indefinitely. But you can pull the plug anytime you want. There's no reason for anyone to dictate what you should do. I just want to give you information. Your choice. I'm just offering my opinions.